A 25-year-old man presents with a painful laceration of the forearm following a bicycle accident. The laceration transects the supinator muscle. The patient's physical examination shows his fingers held in flexion at the metacarpophalangeal joint and thumb held in adduction. Which anatomic structure has been injured? A. Median nerve. B. Musculocutaneous nerve. C. Radial artery. D. Radial nerve. E. Ulnar nerve. Answer is D. Radial nerve. Motor function of the radial nerve is tested by having the patient extend the wrist against resistance. Proximal injury to the radial nerve causes a condition known as wrist drop, in which the fingers are held in flexion at the metacarpophalangeal joints and the thumb is adducted. A young man presents after a fight complaining of a cut on his finger. On physical examination, you note a deformity to the distal second phalanx with a laceration to the second metacarpophalangeal joint. What is the best management for this patient? A. Antibiotics, splint, and follow-up with hand surgery. B. Irrigation, topical antibiotic, and splint. C. Radiography, hand surgery consult, and antibiotics. D. Radiography, laceration repair, and splint. E. Radiography, urgent hand surgery follow-up, and cephalosporin. Answer is C. Radiography, hand surgery consult, and antibiotics. Lacerations or puncture wounds over the dorsum of the metacarpophalangeal joint associated with a metacarpal head fracture should be considered open until proved otherwise. Such injuries are often caused by a clenched fist injury and are highly contaminated wounds. Emergent consultation with a hand surgeon for operative debridement and irrigation is recommended. Prophylactic coverage with a cephalosporin is routinely recommended, although those with highly contaminated wounds also should receive penicillin with a beta-lactamase inhibitor and an aminoglycoside. A 27-year-old woman was playing basketball and jammed her ring finger on the basketball. She presents with her ring finger held in flexion at the proximal interphalangeal joint and hyperextension at the distal interphalangeal and metacarpophalangeal joints. What is the next step in the management of this patient? A. Splint proximal interphalangeal in extension, allowing free movement of distal interphalangeal and metacarpophalangeal. B. Splint proximal interphalangeal in extension, metacarpophalangeal in flexion. C. Splint proximal interphalangeal in extension, with full immobilization of digit. D. Splint proximal interphalangeal in slight flexion allowing free movement of distal interphalangeal and metacarpophalangeal. E. Splint proximal interphalangeal in 90 degrees of flexion and extension of distal interphalangeal and metacarpophalangeal. Answer is A. Splint proximal interphalangeal in extension, allowing free movement of distal interphalangeal and metacarpophalangeal. This patient presents with a boutonniere deformity, which is a disruption of the central tendon causing disruption in the extensor mechanism of the finger. Patients with suspected closed central tendon injuries should be treated with splinting of the pip joint in full extension for 5 or 6 weeks. Only the pip joint should be immobilized, and passive and active dip joint flexion is encouraged from the outset. Operative repair may be required for an acute, closed boutonniere injury associated with a displaced avulsion fracture and injury with volar pip joint dislocation. Early referral to a hand surgeon is advised. A mechanic presents with a complaint of right index finger fusiform swelling and pain following an injection injury with a grease gun. Which of the following approaches best describes the appropriate management? A. Digital block, elevation, and urgent surgical consult. B. Digital block, splint, and outpatient antibiotics. C. Digital block, splint, and urgent surgical consult. D. Parenteral pain medication, splint, and emergent surgical consult. E. Parenteral pain medication, splint, and outpatient surgical evaluation. Answer is D. Parenteral pain medication, splint, and emergent surgical consult. Initial emergency department management includes splinting, elevation, tetanus prophylaxis, analgesia, and broad-spectrum antibiotics. Digital blocks are contraindicated because of the potential for increased tissue pressure, which may aggravate vascular compromise. Emergent hand surgery consultation is warranted because most cases require early extensive surgical decompression and debridement. Which of the following are diagnostic criteria for flexor tenosynovitis? A. Flexor contracture, flexor fluctuans, digit held in flexion, flexor erythema. B. Flexor tendon tenderness, pain on passive flexion, symmetric swelling, digit held in flexion. C. Flexor tendon tenderness, symmetric swelling, pain on passive extension, digit held in flexion. D. Pain, paresthesias, pulselessness, pallor. E. Pain out of proportion to physical examination. Answer is C. Flexor tendon tenderness, symmetric swelling, pain on passive extension, digit held in flexion. 4 cardinal signs of acute flexor tenosynovitis, convulsive signs, are usually present and help differentiate tenosynovitis from other soft tissue infections in the hand. 1. Tenderness along the course of the flexor tendon. 2. Symmetric swelling of the finger. 3. Pain on passive extension. And 4. A flexed posture of the finger. All 4 signs may not be present early in the course of infection.